Okay, so we're recording now.
Yeah.
Okay, so I'll just start. So I'm not quite sure who's there, but anyway, I'm going to talk a little bit about the acute management of the critically ill child, which is kind of a vast topic, but I'll try and sort of just give an overview and a starting point for how to manage these kids. And I have to say, at first, I was a bit like, why do you want to know this? So I had a quick look at what is actually in the curriculum for pediatric intensive care. And obviously, it really depends on where you end up working, but everywhere has a different setup. And so just even at Barnet, it's actually the intensive care consultants who look after kids. So obviously, you do need to have some awareness of how to manage these children. And I think the key thing that I was going to focus on was really resuscitation, stabilization, and transferring these acutely ill children. And that sometimes, depending on the time of year, that period can last quite a long time before a pediatric retrieval team will come and get these kids. So in terms of what I'm going to talk about, it's relatively straightforward. I'm just going to literally run through A, B, C, D, E. You guys obviously do this all the time, but I'm going to try and focus on the aspects that are different in children compared to adults. And then I'm just going to talk a little bit through about the common presentations that children come to ED with. And how to manage them. Again, focusing on the pediatric element of it rather than adult things. So just starting with the beginning, just a quick chat about children's airways. They are different. Generally, they're usually not that difficult to manage as long as you're aware of the differences. And just talking through this slide here, you can see the starting thing is they've got big tongues. Their tongues are like similar size to adults in a very small mouth. So they easily flop back and they lose their airway and they obstruct. And also when you do laryngoscopy, sometimes getting that tongue out of the way can be quite tricky. Going down the neck, they've got their epiglottises are quite different. Again, they've got this big floppy epiglottis. And with an adult, typically when you put the laryngoscope in the vallecula, the epiglottis just moves out of the way and you get a view of the cords. That doesn't happen with young children, particularly the sort of under 1-year-old group. They've got this big floppy epiglottis, and what you need is actually a different technique of laryngoscopy. We typically use a straight blade, a Miller blade, and we lift the whole epiglottis out of the way to get a view of the larynx. And the other sort of really key difference, I think, in how you manage them is basically they've got large occiputs. So actually, the first thing I do when I get given a child is I chuck away the pillow. Children don't need pillows. What you end up doing is you just flex their head and you obstruct their airway. In fact, they often need the reverse. They need some kind of support under their shoulders to help open up their airway. So they're not difficult airways, but they are different, and you just need to appreciate the differences. And then just sort of more physiologically and functionally, how children's breathing differs. Kids have small airways. Obviously, that kind of sounds obvious, but I mean smaller in relation to their size in general. So they're very liable to obstruct. And that can just be with mucus plugging or any foreign body. They obstruct very easily. They're real diaphragmatic breathers, so they don't really have the ability to increase their tidal volume. The way in which they increase their minute volume, they have to increase their respiratory rate, and that's the only thing they can really do. They've got much more horizontal ribs, and they don't really expand in the same way as adult ribs do. They've also got more compliant chest walls. So again, it's difficult for them. If they take a really deep breath, in an adult, you generate negative pressure and you get an increased tidal volume. For these kids, what you actually see is as they try and generate this negative pressure, their very compliant chest walls actually just get drawn in. And that's why in children, you see this intercostal recession and supracostal recession that you just don't really see in adults in the same way. They tire quicker. They've got their muscle fibers, they've got fewer sort of fatigue resistant muscle fibers than adults, so they get tired. And combined with that, they've got high metabolic rates. They consume a lot of oxygen, children. They've got high metabolic rates, they've got high heart rates, they've got high respiratory rates. And so they become compromised quicker. And finally, in the little ones, the sort of under 6-month-olds, just to remember, their oxygen dissociation curve is shifted to the left, and that's because of the presence of fetal hemoglobin, which they've still got. So they have a sort of reduced affinity to give up the oxygen to the tissues. So in terms of how you assess these children, so I've put talking about using reference tables. I think people find it's very difficult. Nobody can remember those reference tables. They're huge tables with heart rates and blood pressures and, for the age of the children. And so they're a starting point, and all these things are available in EDs, but you're never going to remember them. So for me, I think the key is really just looking at the trend in these children. They sometimes come through the door and they've got respiratory rates of 60, 70, almost too fast to count. But the key is to look at the trend of what's happening to them as to whether your child is getting better or not, rather than worrying about the absolute values sometimes. Other things to consider, obviously, we always try and monitor the SATs, but in practice, more often than not, when I go to a sick baby, actually, we haven't got any SATs monitoring because they're crying, they keep falling off, we can't get a trace, and it's quite difficult. So you need to sort of make a global assessment. I've already touched a little bit about looking at the work of breathing. So you see this sternal and intercostal recession, and it can be really marked and quite extreme in a way that just doesn't happen in adults. And it's quite a useful clinical sign of how hard these children are working. And it's a good reason to sort of physically review these children repeatedly, so you can get an idea of how hard they're working and whether they're improving or getting worse. Obviously, listening for stridor and wheeze, children become stridulous more easily than adults. As I've already said, they've got smaller airways relatively for their size, and wheeze is a really common presentation for kids as well. Obviously, looking at cyanosis, and then going back to the respiratory rate. So I think respiratory rate is a really important marker of assessing these kids. However, you just need to be very clear what you're seeing with the respiratory rate. It's very common for a young child, an infant, to come in with a respiratory rate of 60, and you might give them some oxygen, basic treatment, come back and reassess them, and you may find their respiratory rates dropped to, 40 or 50, and that might be that they're getting better. However, the other thing that you need to be aware of, it might be that they're getting exhausted. And sometimes they come in crying with a respiratory rate of 60, and then they're settled with a respiratory rate of 40. And that might actually represent impending exhaustion. And the only real way to sort of decide which way that's going is to look at a blood gas and see what's happening to their CO2 particularly. Circulation assessment, all the usual things, but I think the key thing is a heart rate of under 60 in a child is a pre-terminal sign. It is not normal. Certainly any infant under 1, a heart rate of 60 is highly abnormal. And actually, sort of in terms of APLS guidelines, it's an indication to start CPR. Capillary refill time is what sort of all paediatricians really sort of base their fluid status assessment on. And really, that's the important thing to do there is central capillary refill time, and it needs to be done properly. It's a proper 5 seconds, and then you count how many seconds it takes for that to refill. You can do peripheral capillary refill as well to just give you an idea of the difference between central and capillary, but it's central capillary refill time that's key. Blood pressure is generally not very useful. In fact, often, it takes ages before we get a blood pressure measurement because it's just not a priority, and it takes, and the kids are moving around and we can't get it to measure properly. Once they become hypotensive, that's a very late sign. So, don't be reassured by a normal blood pressure. They maintain their blood pressure for a long time. And then the other thing, to consider is looking at JVPs, often difficult, but also feeling for a liver edge. Remember, in your sort of differential for these children, there are a few that slip through that have undetected congenital cardiac abnormalities and come in heart failure. So it is useful to just feel for a liver edge. And along with that is just to palpate for femoral pulses. Okay, we do get some kids who've got missed congenital abnormalities, things like hyperplastic left heart or cooptation. So just have a quick check to check they're there. In terms of disability, that's kind of easy in a kid because we don't worry about GCS. It's impossible to do a GCS on an infant. So it's a very simple system. Basically, alert, responds to voice, responds to pain or unresponsive. Obviously, other things to just have a look at is just general posturing. If they, think there's been an intracerebral issue, and have a look at their pupils. And that's pretty much all you can do. And then finally, main thing there is don't forget their temperature. Kids often come in, kid presenting febrile is a very common presentation for all sorts of reasons. And those temperatures need treating, particularly if they're high. Kids fit very easily with a high temperature, and again, in a way that adults don't. Finally, they may well be hypothermic as well. Children lose heat very rapidly. They've got large heads in proportion to the rest of their body. They get cold quickly. So just check the temperature, and then obviously just make sure you have exposed all of them. Make sure that you haven't missed a non-blanching purpuric rash, and just check, is there any bruising? Is there anything else going on? Obviously, you just always need to bear in mind the possibility of non-accidental injury when a child comes in unspecifically unwell and you're not clear on the history. So the other thing I thought I'd just touched upon in terms of the assessment and things that we use is capillary blood gases. So we use, obviously you're all used to looking at, arterial blood gases all the time. However, in children, we tend to do capillary blood gases. The reason being is they're very simple and safe to do. The other thing is actually technically putting an arterial line into an infant's really quite difficult. Particularly, it's fine if they're anaesthetised, but if they're awake, it's actually incredibly difficult. On top of that, they've got small arteries, and actually you can occlude the whole artery by putting an arterial line in. So it's not something we do lightly. We only do it if you absolutely need it. But yeah, it's just how they correlate with arterial blood gases. So generally, there is a sort of clinically acceptable agreement between capillary and arterial gases. And most studies that have compared the two sort of will say that you've got an acceptable agreement between what they call an arterialized capillary PCO2 and arterial PCO2. So generally, the pH and the PCO2 are much the same between your capillary and your arterial blood gases. I think where everyone would agree there is a difference is really in the arterial PO2. And studies have shown different things, but you generally have a difference of 2 to 3 kilopascals in your arterial PO2 versus your capillary PO2. But the difference is really your arterial venous difference. So if you have a child with a normal PO2 of 13, arterial PO2 of 13, and a venous PO2 of 5, then you might expect a capillary PO2 of maybe 10 or 11. However, if you've got an increased AV difference and you give lots of supplemental oxygen and the child has an arterial PO2 of 30, you're going to see a much bigger discrepancy with your capillary PO2. So again, I think the key thing here is when you do repeated capillary blood gases is to look at the trend. The pH and the PCO2 are reliable. The PO2 is much more variable. Excuse me. So in terms of how you're going to actually manage the kid, so we talked about this a little bit already. Basically, you need to open their airway, basic manoeuvres. Shoulder roll is often needed. You often need a Goodell. They've got big tongues. If you can tolerate it, that's what you should use. I've put in here infants. This is a sort of APLS exam type position. Infants need a neutral position. Children need a slightly more extended, bigger children need a slightly more extended position, which they talk about sniffing the morning air. I don't know how useful those descriptions really are, but they will, just have an idea in your mind of what you're trying to do. They do obstruct easily, and I think a really important thing is often in an attempt to open kids' airways, people try jaw thrusts, they try chin lifts. The key thing is sometimes the person who's trying to open their airway actually obstructs it with their fingers. They've got lots of soft tissue around their chin. It's really important that when you hold a kid's airway, you make sure your fingers are only on the bony points. So obviously, once you've opened their airway, the usual high flow oxygen. Something that's really important, which is again less of an issue in adults, if you need to bag valve mask ventilate a child with some manual support, you need to be really, really careful about inflating their stomach. It's very easy to do, and if you're squeezing in too much pressure, you put air in their stomach. As I said, they're diaphragmatic breathers. As soon as you inflate their stomach, you splint their diaphragm and they become unventilatable. And the harder they are to ventilate, the harder you squeeze the bag, the worse the situation gets, and you can really spiral into problems really quickly. So it's really important you've always got a method to deflate their stomach, and that can be passing an NG tube sometimes. Sometimes it's just passing an ET suction catheter rapidly into their stomach connected to some suction. So that's really important. And then sort of the next maneuver we would do with any kid who is desaturating or just struggling is we would basically use Optiflow or Vapotherm. These are just trade names. At the Royal Free, we've got Vapotherm. It's just a high flow humidified nasal oxygen. So the key things just to say, though, hypoxia is the commonest cause of cardiac arrest in children. So you've got to correct their hypoxia, and they tolerate hypoxia very badly. And the other key thing is, like I said, every child is different. So whatever you do to open their airway, you need to keep reassessing. And they've got small tidal volumes, so you just need to pay quite a lot of attention to the fact that their airway is open. And I would always recommend, particularly if you're using a bag valve mask or anything, to always put inline CO2 in that circuit, even prior to intubating them. So this is just a little thing. This is just to show you that the Vapotherm is our first line therapy at the Royal Free and equivalents in other trusts. And basically there are all these things have settings for how you start them, and it usually goes up to 2 litres per kilo of flow, and you titrate it up. They come in different sized cannulas, and then the two things you can titrate is obviously the FiO2 and the actual flow rate separately. And obviously the paediatric nursing staff should all have training in how to use this. So moving on to, if you actually decide you do need to intubate them, I would, nobody intubates really sick infants day in, day out. So it's always something that's a bit exceptional. And I would always advise using a checklist pre-induction. I think, I don't know if you guys already use a checklist on ITU. I think maybe as anaesthetist, because we intubate people so often, we're a bit blasé and we don't bother with checklists. But I think here there really is a role for them for everybody. Mapleson F circuits. I don't know if you're familiar with Mapleson F circuits. They're effectively, I've got a picture of one. Hang on. There you go. That's a Mapleson F. I don't know if you can really see that. But basically, it's a bit like your water circuit that you use in ITU. The difference is it's got no APL valve. And the way that you release the pressure from the system is that the bag here, that's got a cut-off end. So the gas just escapes through the end of that bag, and you use the bag to control the pressure and the and that's how you ventilate them. It's a circuit that if you don't know what you're doing, you can easily hypoventilate them, or hyperventilate them with very high pressures. And the risk is you can cause a pneumothorax or put air in their stomach if you haven't secured the airway. So I would recommend you only use them if you're familiar with them. Otherwise, just use a pediatric ambu bag. It's safer. Try and pre-oxygenate these kids. It can be really difficult, but you have to just do your best. In terms of sort of rapid sequence, I mean, these children always need ventilation post-induction before you intubate them. I would never dream of giving them muscle relaxant, rock, sucks, anything, and just waiting. They will desaturate horribly, and yeah, always ventilate them. Again, going back to deflating the stomach, make sure you've got a plan to deflate it. And sometimes that's having one person dedicated to continuously aspirating an NG tube that's in situ, or it's having some device ready to put into their stomach if necessary. Check all your equipment. That sounds really obvious, but unlike in adults where you just say, right, I need a blade, a tube, you've got to choose what size of tubes you're going to use. And that's, to be fair, always an estimate because you don't necessarily know. So choose the size you think you're going to need. Always have the size below and the size above. You also need to choose whether you're going to use a cuffed or an uncuffed tube. And I think I'll talk a little bit more about that at the end. That's a conversation that paediatric anaesthetists can run with for a long time. Bougies, that's kind of obvious, but you need to literally physically check everything. It is not uncommon to find that you need to use a bougie. You put a bougie into the airway and then the tube that you've selected doesn't actually fit over the bougie. There are multiple sizes of bougies to go in different sized tubes. So you need to physically check everything before you start. And finally, just check your ventilator settings. It's really easy to just connect it up, and I would always advise of avoiding volume control ventilation because the risk is you accidentally give a vastly inappropriate volume to a child. If you've got pressure control settings, you're unlikely to do any major harm. So we've talked about the Mapleson F circuit. This is just an example of an intubation checklist. It's on the CATS website. And so the CATS website, I can't recommend to you enough. All this stuff is there. So it's really useful, and it allows the whole team to check together that you're actually ready. So finally, circulation management. So obviously get IV access as you would normally do. Things are a bit different. You can look in kids' babies' scalps. I know that sounds a bit weird, but it is somewhere where we're struggling. We do often put cannulas in. Bizarrely, sometimes when you look at a vein, you're not quite sure which way to put the cannula in because you're not quite sure which direction the blood drains in. If you're not sure, you can always occlude it and see which side fills up. External jugular, another one we sometimes use. Difficult with a screaming, wriggling child, though. Really low threshold for IO access in children. So I think the APLS manual talks about trying for no more than a minute or 3 attempts. I don't know that we all go straight for IO after a minute, but it is often a good rescue access for children, and I think we are using them more and more. First thing is to get a fluid bolus in, and we usually start a fluid bolus in a kid is always 20 mils per kilo of crystalloid, usually normal saline, unless you think the child has cardiac issues, in which case we'd start with 10 mils per kilo. So in terms of when you get to this child, you need some emergency calculations. And I have to admit, these are your bog standard APLS calculations, which I never need to do, to be honest. When I arrive, the ED guys are really good. They've usually always done this already. So it's weight, and that's, again, a real estimate, age plus 4 times 2. I'm sure you're fully aware of how much children vary. And it only really works for children at least over the age of 1. On the plus side, smaller kids, Usually they get weighed, particularly the little ones at birth, they get weighed quite frequently. Often the parents are the best source of knowing what the weight of the child is. Energy for if you need to shock them, which is incredibly rare in a child, it's 4 joules per kilo. ET tube sizes. So we talk about age divided by 4 plus 4. I would say that'll give you the size for an uncuffed tube. If you've decided to put a cuffed tube in, you need to go half a size smaller. Fluid bolus, I've talked about already, is 20 mils per kilo. Lorazepam, kids come in fitting quite frequently. It's one of probably the top 2 reasons we get called. And the dose of lorazepam is 0.1 milligrams per kilogram. Adrenaline dose, 0.1 mils per kilo of 1 in 10,000. And glucose, kids become hypoglycemic quite quickly in a way that adults don't. Just for, babies don't tolerate not being fed, and they don't have the liver glycogen stores that adults do. So always check a glucose in any kid who comes in sick. And the treatment is 2 mils per kilo of 10% dextrose. So what makes children short of breath? This is not in any way an exhaustive list. It's the things that make children short of breath that generally don't make adults short of breath. So I've sort of listed them there and given you an idea of which ages they present in, because often actually the age of the child is your first major clue to figuring out what is going on. 10-year-olds don't tend to come in with croup. So croup is your younger kids, your 6 months to 5 years. Again, it's unusual to see a 5-year-old with croup. They tend to be the younger kids, and they've got this really classic kind of barking cough, and they sound hoarse. And it's most typically caused by a parainfluenza virus. It's common, it's very likely that if you look after kids, you will get called about kids with croup. Epiglottitis, rare. I've personally never seen one, luckily, but it's the kind of bread and butter of anaesthetic exams because it's a real emergency and it's really critical. It's typically caused by a Haemophilus influenza B virus, which children are vaccinated against. But as we see variations in vaccination uptake. We do see these cases. I think at the moment, because of COVID, there has been a drop in children getting their vaccinations. They've just fallen off the usual surveillance. So it's something we do need to be vigilant for. These kids come in looking really sick. They're drooling, they can't swallow. They've got really obstructed airways potentially. They look toxic, they're febrile, and they're really unwell. Foreign body is the other classic pediatric upper airway emergency. Generally, it's the under 3s. That's because partly of the anatomy of the base of their tongue. Food at the back of their mouth is not protected by their epiglottis as well as it is in adults. They don't tend to have well-developed molars, so if they eat solid food, they don't kind of masticate it so well, and then sort of whole bits of food that are the size of a trachea tend to slip down. And also, probably as anyone who's got children knows, toddlers, they just like run around eating. You can't get them to sit still and eat. So another reason it affects this age group. And it's the history that's going to give you that. Child who's been completely well running around, sudden onset airway problem. In terms of going lower down, what gives you lower airway problems? So tracheitis, a bacterial tracheitis can cause problems. Again, these kids look really sick. It's similar to sort of epiglottitis. They're really toxic. They're febrile. They've got horrible purulent secretions. It's typically caused by Staph aureus, and these children are really unwell. And bronchiolitis, I've put bronchiolitis in bold because bronchiolitis is the most common thing. So it's basically usually a viral related induced wheezing disorder in the under 1-year-olds. It's really common. About 10% of infants get bronchiolitis at some point, of which about 2% of them actually need intubating for it. So they come in typically with this fever, dry cough, then they're wheezy with respiratory distress. Asthma, obviously kids get asthma, but that's no different to adults. And then sort of pneumonia, again, that's no different to adults particularly. Neuromuscular disorders is another one. More often than not, when we get called to critically ill children that need PICU input, usually these children are not completely, well, no, often these children are not completely developmentally normal. And so they may have some neuromuscular issues on top of a, respiratory infection. So these things can combine. So just sort of very basic management of these, sort of individualized managements of these treatments. Croup, first line therapy is really nebulized adrenaline, okay, and then either oral or nebulized steroids. Epiglottitis, I think the key thing about epiglottitis is that you need senior help rapidly, and you need ENT on site. These children can completely obstruct and may need emergency tracheostomies. So get the right people in the building. Don't attempt to put these kids to sleep sort of in ED or anything. Ideally you want these children in theatre as calm as possible. Try not to upset them. Even just trying to get IV access can cause a kid to lose their airway. So, the classic is that you try and put them to sleep and as calmly as possible with a gas induction on the parent's lap before you try and secure the airway with an ENT surgeon standing there on standby. That's the sort of textbook teaching. As I said, I've never personally seen an epiglottitis. I'm sure it would not be actually that calm in reality. Once you've secured their airway, obviously, then the mainstay of treatment is antibiotics and supportive therapy. Inhaled foreign bodies, same really in terms of you need help and you need to get these kids to theatre. And the one thing you just need to be really careful of is, as much as possible, trying to not to intervene and not to give these kids positive pressure ventilation. You risk dislodging whatever it is that is partially only partially obstructing them to completely obstructing them. And the worst case scenario is you positively pressure ventilate them and you dislodge something that's around the cords and it lodges around the carina. So again, we avoid positive pressure ventilation for that reason. Tracheitis, this is rare, but this is really life-threatening emergency, and almost all these kids end up needing intubation and ventilation. And you get literally like sloughing around their trachea. So you might generally above the cords should be relatively normal, but you may well need a smaller ET tube than you imagined if there's a lot of swelling below the cords. And then again, it's IV antibiotics and supportive therapy. So bronchiolitis, this is our bread and butter. This is what basically we get called about throughout the winter. The management of it is largely supportive. The kids tend to be small. Risk factors for bronchiolitis is, ex-prem, ventilated at birth, small babies. So it's often like 3, 4, 5 kilo babies that need intubating for bronchiolitis. The older kids get, generally, the more robust they are. The other thing that happens in this age group specifically, which you don't get in older children and adults, is they've got really immature, underdeveloped respiratory centres. And so they just have apneas for no particular reason. Sometimes you try and put an IV cannula in and you upset them and they become apneic. Or the other classic is you see a child who's unwell, who's not feeding because of bronchiolitis, and the paediatricians try and pass an NG tube for some NG feeding, and just the attempt at trying to pass an NG tube renders them apneic. And of course, if they come in with bronchiolitis, they really can't tolerate an apnea. So that's often a common indication for intubation, and something it needs to be monitored for. Despite them being wheezy, there's no real evidence that bronchodilators, as in salbutamol, really has any effect in these children. They don't have the receptors in the same way as older children, and it doesn't really have any effect. So generally we don't, you might try one and see if it has any effect, but generally we don't bother with nebulizers. The mainstay of treatment is high flow humidified oxygen, your vapotherm, and failing that, intubation. Moving on to shock. So gastroenteritis can leave kids shocked just because they're small and they've got and they get dehydrated really easily. So it's not to be dismissed. It can really make kids really dehydrated. The other one is the big one for us is sepsis. And kids who come in with sepsis can be really sick and really quite difficult to manage. Obviously, anaphylaxis, and then your cardiogenic causes, and that's either sort of, pump failure itself because of congenital heart disease, valvular disease. In the older children, they're more at risk of the sort of post-viral myocarditis. Kids with arrhythmias usually have got some underlying inherited or congenital cardiac problem. And then obviously sort of obstructive congenital cardiac causes, things like coarctation, aortic stenosis, and hypoplastic left hearts. So in terms of how you manage these, it partly depends on the cause. Obviously, whether this is sepsis, gastroenteritis, and these kids need volume, or whether you think this is cardiogenic. And obviously the history is what's going to be key here, and also the age of the child. Okay, so the classic is the kids who come in who are a few days old, who have suddenly deteriorated. These are the kids you need to be suspicious of whether they've got undiagnosed congenital heart disease, who've had duct-dependent circulations, and their ductus arteriosus is just closing off now. So management, IV, IO, we've talked about. Give them a fluid bolus. In the kids with sepsis, indication for intubation, the trigger for intubation is 60 mils per kilo of fluid. These kids some of the kids, particularly with like a meningococcal septicemia, they have vast fluid requirements. They can need sort of 200 mils per kilo of fluid. And once you start getting above 60 mils per kilo, you start running into problems with ventilation. They get peripheral edema, pulmonary edema. They can't oxygenate them, and you can't. And also they've generally become edematous, and intubation becomes difficult. So it's quite normal for the paediatricians to call us once they've given 40 mils per kilo and the child is not dramatically better, to say, I think the child's going to need a further fluid bolus. And we tend to intubate and give that further 20 mils per kilo sort of at the same time generally. Again, this is the sort of just so you can see it, this is on the CATS website. It's a sort of pediatric sepsis 6. It's just a sort of checklist of everything to think about in the management of a kid with sepsis. All these resources generally in most pediatric EDs are either easily available online or they're in a folder. So it's really useful, to have some frame of reference, so you don't stand there thinking, oh God, I never deal with sick kids, what am I doing? Just to have something in front of you to work your way through, to make sure you haven't missed anything obvious. And again, this is the CATS guideline on how to manage shock in children. Our first line inotrope generally in children tends to be adrenaline. And the reason for that is partly mainly practical actually. So there is a protocol, a CATS protocol for giving peripheral adrenaline. So it's easy to set up, and we tend to run it. So and often if you have a kid who's septic and you speak to CATS, our retrieval team, they'll often advise you to have the adrenaline infusion running for induction itself. So just a quick mention, again, duct-dependent congenital heart disease. So this is just sort of, for a non-pediatric cardiologist or a non-PICU intensivist, this is just a bit of a nightmare. So I think the key about it is thinking about it, remembering to think about it, because children who are a few days old, babies, they just present really non-specifically unwell. Often the presenting complaint from the mother will be not feeding, and that's it, and that's all you've got to go on. So just think, could this be congenital cardiac disease that we don't know about? So the kids who are hypoxic and cyanotic and they don't get better with oxygen is a key feature. Raised JVPs is always in the books. I think it's incredibly difficult to see a JVP in a really sick baby. People talk about gallop rhythms. That's often quite difficult as well, because these kids have heart rates of 150, 160. It's very difficult to hear much, particularly in a busy ED. If they're looking very tachycardic and that's sort of disproportionate to their respiratory difficulty, that is something to be aware of. And again, looking for enlarged liver or absent femoral pulses is a sort of marker that there may be an element of that congenital heart disease is an issue. So there's kind of two types of lesions. Those that reply have a duct-dependent pulmonary circulation. So when the duct closes, they lose their pulmonary circulation. And those are kids basically who've got right-sided lesions. The blood cannot flow out the right side of their heart to get around the lungs. And the only way it goes around the lungs is through the ductus arteriosus. And then the other group are dependent on their duct to generate a systemic circulation. So those are the kids who've got obstruction of the left side of their heart, coarctation, aortic stenosis, or a hyperplastic left heart. These kids, they all present within a sort of generally in the first week or so of life, and with a sort of cardiogenic shock, shortness of breath. But like I said, they may just present with inability to feed. If you suspect this is what it is, you need to get expert advice. And if you phone CATS, they always have a consultant on hand. They will give you advice. And the sort of treatment is to start a prostin infusion. So you use an IV infusion of dinoprostone, and that all, how you draw it up, what you do with it, is all, again, on the CATS drug chart and website. And I'm referring to CATS because obviously that's what we use in North Thames. But South Thames, Evelina, STRS, they have exactly the same. All over the country is covered by paediatric retrieval teams, and they've all got their websites with all the guidelines for this stuff. Finally, seizures. So seizures is probably up there with the other second. Bronchiolitis and seizures is basically why we get called repeatedly. Fevers, kids get febrile convulsions. They've got poorly developed brains. Their ability to control their temperature is less than adults. You know, kids can have temperatures of over 40 with a viral illness and cause them to have seizures. Obviously, consider meningitis and encephalitis as a cause. Some of the kids have known epilepsy, and obviously the seizures might be secondary to hypoxia or metabolic issues, particularly DKA, trauma, obviously. And obviously the key there is to treat the cause. Aside from treating the cause, this is the algorithm for treating status. And it's very stepwise, and it gives you a time frame. Basically, you start with some lorazepam, you give a second dose, and then you give some phenytoin. And if that's not worked, you eventually end up with a rapid sequence with thiopentone, according to, this is the APLS guideline. And certainly that will be a logical choice if you failed to stop fitting with phenytoin and lorazepam. And then finally, just looking at causes of reduced GCS. Again, very similar to the causes of reasons why kids fit: abscesses, meningitis, metabolic things. So hypoglycemia, we've touched upon, DKA. What I would say is kids often present, their first presentation of diabetes is very sick in DKA. So just because there's no history of diabetes doesn't mean they're not in DKA. So that's something to think about. Obviously, any other metabolic abnormalities. Intoxication is another one to think about. 2-year-olds, they crawl around, they find things, to just be aware that it's a possibility they may have accidentally ingested something. So you just need to have it in the back of your mind as a possibility, and to try and probe for the history if you think that's a possibility. The raised ICPs, sort of AV malformations. Some children have AV malformations, usually diagnosed antenatally if they're big ones, but not always. And if they bleed, they can obviously cause problems. And cerebral tumours is another one. They tend to present a little bit later, often in your sort of early school age children. So again, that's why bearing in mind the age of these children will just give you an idea of what might be a likely diagnosis. So common questions people ask, these are very sort of practical questions, but actually important. What drugs are you going to induce these children with? Generally, I use ketamine for induction for all these kids. The only exception is the kids with status, where I think thiopentone is a more sensible choice. You can use propofol for kids that are fitting, but some, particularly GOSH, are very anti-propofol. The PICU is very anti-propofol, so would they advise thiopentone? How to draw up your drugs. That sounds like a really sort of stupid point, but you need to think about it in advance, because you need to be, what I would suggest is that you always draw up your drugs the same way, and you need to decide, do you want to draw up your drugs neat or do you want to dilute them? Sometimes you're talking about tiny doses of drugs. It can be that your induction dose of fentanyl is going to be 0.1 of a mil. So you just need to think through how you're going to do it. And importantly, you need to really clearly communicate with whoever you're working with how you've done it, because often one of you takes the airway and one of you gives the drugs, and if there's any confusion about the dilutions or the dosing of the drugs, so you just have to be absolutely clear about what your system is going to be, and you always stick to the same system. Emergency drugs. So, when we intubate adults, we've always got metaraminol and ephedrine around. Generally, the only emergency drugs I have for kids are atropine and adrenaline. And I usually draw up in a 10 ml syringe, effectively an arrest dose of adrenaline, and then you can give, which is 10 mics per mil. And if you draw that into a 10 ml syringe, then you can give 1 ml boluses, which are 1 mic per ml boluses in an emergency. Cuffed versus uncuffed. Sorry, the other emergency drug to always remember is sucks. And the reason I don't tend to use sucks for induction of these children, I tend to use rock. But the key thing about sucks is you can give it IM. So if you lose your IV access, or there's some drama and you've lost control of the airway and your IV access is a problem, you can at least always resort to giving IM sucks. Cuffed versus uncuffed tubes, big debate, but the reason historically we've used uncuffed tubes in children is because their airway is sort of conical shaped, and they're unlike adults, the narrowest part of an adult's airway are their vocal cords, whereas in a child it's below the vocal cords. It's sort of more conical shaped. And if you have a cuffed tube putting pressure on the trachea, the risk is you get tracheal necrosis much more easily, and you get tracheal stenosis long term. And so we've always historically put uncuffed tubes in. However, if you are then putting a kid to sleep who's really sick, the advantage of a cuffed tube is, firstly, as long as the cut tube is not too big, it's less critical that you get exactly the right size tube, because obviously you can inflate the cuff to make it fit. And the last thing you want to do when you've just tubed a child that's been difficult is to realise that the tube you've just put in is too small and there's a massive leak and you can't ventilate them, and to realise you're going to have to change that tube and go through that all over again. So that's the biggest advantage of a cuffed tube. The other thing is if you've got a kid with abnormal lungs and high airway pressures and difficult to inflate their lungs, you're going to struggle with an uncuffed tube, even with a very small leak. So generally, I go for a cuffed tube for critically ill kids going to PICU. The other thing you have to think about, and I'm not going to go into it now, but you've got parents in the room and you need to think about what you're going to do with them, how you're going to communicate with them. Where are they going to go? Are you going to keep them in the room? Are you going to ask them to step outside? Certainly at the moment, given, kids we intubate are at risk of potentially having COVID, our general rule is we keep the parents in the room. Partly because I don't want, if you think the child's got COVID, the parents have been exposed, and we don't want them wandering all over the A&E department. So partly about containment, but you just need to work out in your mind what you're going to do with the parents, and that you're happy with them being in the room and watching everything, which is something that obviously never really happens with adults. And the other thing is communicating with your local retrieval service. Keep them in the loop, speak to them. You want them to come and get these kids as soon as you've intubated them. You do not want to be stuck with intubated children in your ED for hours on end. And it can happen. We've had children for 12, 18 hours in the winter months in ED waiting for cats to come and get them. So the sooner you get them dispatched to you, the better. And the other thing is, I think it's important to say, is they are brilliant for advice. They're very experienced. They're very helpful. And generally, you follow their advice and all is well. However, at the end of the day, you are the clinician with the kid in front of you. So it really is your responsibility. And if you really think that a child needs to be intubated, regardless of what they say, you have to make that decision. So they're there to help and support, but ultimately, until they retrieve the child, they are still our responsibility. And again, that's just another example. This is on their website. You just print it off. What you do is you just type the weight into that box, and it will just automatically populate all these fields for you. And it has all the inotrope doses. It has the prostin doses there that I mentioned. It's got all the sedation. So yeah, use all the resources available, and it makes things a lot less stressful. So finally, the few take-home points. Kids present with really non-specific symptoms. Yeah, the presenting complaint, not feeding, is really common. And it gives you no clue whatsoever. So you just have to be really open-minded when you assess these kids. Hypoxia is the big killer, and you've got to treat it, and quite aggressively. The other thing about kids is they get better really quickly, and they also deteriorate really quickly. And you sometimes get called to a kid in ED and you think, oh my God, they look like they're going to arrest, and you start to get ready to intubate them. And actually, by the time they've had one nebulizer, they're kind of chatting. So they can, they turn around much quicker than adults. But the reverse is also true. So you might see a kid and they look all right, and then suddenly half an hour later, they're peri-arrest. So you've got to keep reviewing the kids with a sort of quite short time frames to be clear which direction they're going. I've already said use all the locally available resources. And just finally, unless you work in PICU all the time, kids are totally unpredictable. You see children in situations that you would just instantly think it's unsurvivable. And if you had an adult in that scenario, you'd be discussing withdrawing treatment. You can never tell with children. We've had children arrested with pHs of 6.8 who've actually been discharged home like 4 days later. So they are physiologically quite remarkable in that respect. So never withdraw treatment on a child without sort of senior experienced input. And finally, those are just a couple of websites to where there's a lot of resources. The CAT's website's got a lot. Evelina, I have to say, obviously we are North Thames, but I really like the Evelina website and the guidelines. They've got basically guidelines for all sort of clinical conditions, all on a 1A4 sheet, which I particularly like. And that's it, really. Any questions on what is a lot of information about a whistle-stop tour of peds and ED?
Jude, I think you've covered everything.
Okay.
Thank you very much. It's very educational, very important to us, as we don't have as much experience with children as you do.
Good. Well,
could you just quickly tell us what's happening at the Royal Free? So how we manage a sick child on A&E? So who goes down to A&E? Who intubates? This sort of stuff.
So the setup we have is that the 1707, so the theatre's anaesthetic registrar will be the sort of first point of call, and they get all the paediatric arrest calls or the fast bleeps to A&E. We have one of the anaesthetic consultants on call is always a sort of paediatric anaesthetist, varies slightly to the extent to how paediatric they are. So there will always be a anaesthetic consultant who is available. Now, they may well be at home. So obviously, it depends quite how critical the airway is. Sometimes, though, we do ask the float registrar from ITU to help, particularly if, our anaesthetic registrar is stuck in theatre with a novice or something like that. So you may well get called to help and assist. The other thing is the ODP always goes and the part team always go. So usually we'd never intubate a young child without one of the anaesthetic consultants present. But obviously it does depend how time critical it is. The very little ones, if you get a kid who's like, I don't know, a week old and 3 kilos, the paediatricians are obviously always there as well, and they're often coordinating and running things. But it may well be some of those paediatricians have quite a lot of PICU experience, and it might be that they're willing to intubate the child. So often I think you just need to work as a team and discuss what the skill set is within that team and who's most comfortable, doing whatever it is. So it is a little bit variable.
Brilliant. Thank you so much. Any other questions?
What?
Hi.
Hi. I assumed you were Kate when I saw that name.
No, not a question, but just to say thank you for this talk, Jude. It's very, very comprehensive. Just a couple of points. I'm not sure if you said them because I've been dealing with my own 3-year-old here. I've been in and out of this talk, but something that I found very useful, 2 things actually, is video laryngoscopes down in A&E, or if you bring the child to theatres, can be really helpful as well, just because it gives everyone in the room a view of what the intubated person is seeing. And secondly, it's kind of a rule of thumb, is that I've found, especially when I was more junior, that this 20 mils per kilo, 30 mils per kilo, 50 mils per kilo is quite hard to get my head around. But if you multiply that by your own body weight, it gives you a clue as to how much fluid this child has actually got. For example, I'm just shy of 90 kilograms. So if a child has had, 60 mils per kilo, if that had been given to me, that'd be like 5.5 liters. And you realize that's actually a lot of fluid, even though it may only be, 300 mils in actual volume wise. So just a couple of extra points there. But yeah, thanks for the talk, Jude.
Thanks, Taj. Any more? I'm still slightly getting my head around Microsoft Teams.
Okay, you're not the only one. Okay, shall we call it a day?
I think that's stunned silence, so I will leave it there and stop recording.
Thank you so much.
Okay, thanks, guys.
Cheers.
Bye.
Thanks, Jude.